So Dr. Haripriya, please, we will love to hear your talk now.
Can we have the slides on, please? Thank you, Samaresh, for bringing this important topic to focus. So I think we all now understand that climate change is the biggest global health threat of the 21st century. This has been published in Lancet, and what that leads us to is that it now becomes the greatest global health opportunity, something which we can work on and should work on. I think the time is now. And that's why I think this whole course and this discussion is very important. So there are guidelines for climate-friendly hospitals from the WHO, and this includes being energy efficient, having a green building design, have alternate energy generation using clean, renewable energy, consider transportation, which can be either reducing the fuels or use alternate fuels, consider using more locally grown sustainable foods, reuse, reduce, recycle, compost waste, and conserve water. So I think all of these factors are important, and through the course of the next few slides, I'll be sharing some of the initiatives which we are taking to try to address some of these aspects. So in terms of infrastructure, energy, it's important if we can have, at least the newer hospitals, focus more on more natural ventilation and better lighting. This can reduce the need for electricity, and also have a layout where you can minimize movement. That will be very critical as well. Also, while building a building, I think we now try to focus on using materials which will reduce the maintenance. So you need less water, less frequent effort to try to maintain them. We also have all the housing, at least about 70% of our staff stay on campus. So all our campuses, we have housing on campus, and those who are willing to stay. This also reduces commute and reduces use of fuel. The other aspect is energy. The 75% of energy which we use now at Aravind is clean energy, and this comes from both using of the solar capacities in-house and by procuring clean energy from the private sources. So this is another area which we're trying to look at critically. In terms of water management, the newer hospitals, the last 3 or 4 hospitals, we have a water treatment plant called DWATS, which is actually a very evolved, very good system where we reuse about 90% of the water, and this water is used in the gardens and in the toilet flushes. We also do rainwater harvesting, which I think most of us would advocate for both at our homes and at places of work. So we do realize that the way to go is to reduce, reuse, and recycle. So in eye care setup, how can we focus on this? So by reducing, we want to reduce the number of visits the patient would have to come to the hospital. So we try to focus on finishing as many investigations or touch points on the same day as possible. So if a patient has to see a specialist on the same day, we try and ensure we reduce the number of revisits if it is not required. We also use EMR across our system, and that helps to reduce paper waste. And we have a rationalized use of consumables, and SOPs also help us ensure reducing stocking unnecessary materials, and this can also reduce the need for waste. So reuse is important, multi-use wherever it is possible. So I think there's a lot of focus here. Most recently, I think we had a publication from the American Academy that we can reuse the eye drops for multiple patients. I think we just saw from the earlier speakers, which we've always been doing in India. So I think it is a good idea that you can reuse the same bottle for the next patient as long as you don't touch the dropper tip on the patient's lid or lashes. So, but having very clear protocols for reuse is also very important. And recycling and repurpose is important, so use or dispose of these items is also very critical. In terms of hospital process, like I mentioned, we would try to finish as many investigation diagnoses on the same visit, and having a lean clinical protocol backed with evidence-based medicine is very useful, and having SOPs. The follow-ups, if possible, we'll ask them to go back to our vision centers or community clinics so they don't have to come back to the base hospital, so they reduce the amount of travel time. So the 1 day or 3 week follow-up, they would go to the clinic which is most close to them. Operating room protocols at Aravind, we have been using the twin table system. So each OR, each surgeon has 2 tables which they work on, and the 2 paramedical staff who assist them. And the surgeon also uses the same gown. So we don't scrub between cases, we use the same gown, which is typically linen, which is cloth. And we also clean the operating room floor about once every hour, not after every case. So we had a chance to change some of these protocols during the COVID time, and so we tried to compare and see how does our original protocol compare with trying to have 1 patient in the OR at a time and cleaning after each case does. So we published this paper in BJO last year. We looked at about 85,000 surgeries, about 56,000 surgeries we had done before COVID, and about 29,000 after COVID, during the COVID protocol time. So before that, we had the patients were not gowned, surgical gloves were disinfected but not changed between cases, and the OR floors were not cleaned between every case. And multiple patients underwent preparation and surgery in the OR at the same time. Now, during the COVID pandemic, we had each patient was gowned, surgical gloves were changed for each case, the OR floors were clean, counters were cleaned, and only 1 patient in the OR at a time. So we compared these 2 protocols to look at our endophthalmitis rate, and we found that endophthalmitis rate was similar. So we continue to do our old practices of having 2 patients in the room at the same time and cleaning the ORs about once every hour. But we do change gloves now after the COVID pandemic. Some of the surgical protocols we work towards is to have very stringent sterile protocols and sharing of supplies, and minimize use of single-use instruments wherever it is possible. So looking at the different items we use, like I think again we heard from the previous speakers, it's a good thing to kind of segregate at waste and separate the paper and the plastic. This way you can actually recycle these items. So as you can see here, the plastic drapes and packaging material are disposed and they're recycled and sold, and the medicine and consumable containers are also recycled. The cotton swabs and sharps, etc., obviously go into the yellow bin, biomedical waste disposed. Surgical gloves and syringes are changed for each case, and that is also disposed in the biomedical waste. Surgical instruments, we do use a flash autoclave between cases, and this again is now approved. So each table would have between 10 to 12 sets, and then once you have the sets come in from after the 10 sets are done, we would then have them go through a flash autoclave cycle. The trays and pans get autoclaved end of the day. And the surgery dress and gown, like I said, we use linen. This also helps to reduce waste, and this gets disposed end of the day. So the surgeon wears the same gown and for the entire session. So there is a lot of discussion about use of single-use devices. Can we use them? More than 1 patient. Some of the commonly used single-use devices would be the custom packs, the phaco tips and sleeves, the anti-vitrectomy probe, Simcoe cannula, iris hooks. So we do reuse some of these single-use items. Now, what are the concerns one might have when reusing single-use items? One, that we may compromise on the intended function. Like if we're using a phaco tip, if it's used again, will it function the same way? Second, it may not be designed to allow thorough decontamination. Especially if you have instruments with lumen, you have to be more careful to try and clean them, and the potential cross-infection and endotoxins which may be there and cause any TAS. So when we do try to use, like the anti-vitrectomy probe, our recommended use is up to 5 times, but we have a very clear, stringent protocol as to what one would have to do right after the surgery and at the end of the day, and how you will have to package these items and how many times. So if it is functioning fine, the cutting is good, aspiration is good, up to 5 times, but if it does not function well, or if it functions but it's beyond 5, it has to be condemned. So again, having a good system of labeling to know the number of times it's reused is also very important. So we use the seal which has the date and talks about number of times. So this pouch, so we kind of, after it's been used, the unsterile probe goes back into this pouch until it is reprocessed and re-sterilized and ready for use on the following day or another day. The other aspect I was talking about, are we compromising on the function? Some of these single-use devices, while labeled as single-use devices, so this is one study which was published in 2018, where they compared phaco tips, which were labeled as they could be reused, and some companies labeled their tips as single-use. And they compared both these tips, and they said that actually there was no significant difference in the phaco tip, which were labeled for single use or multiple uses. So I think, it is end of the day, if you are going to reuse some of them, you can test and see how the function is, but more importantly, also ensure that your reprocessing is done in the right way. So the carbon footprint which we generate, now because of this policy of reusing and recycling in Aravind is much lesser than what it is in the Western world. So it's about 1/28th as was shared earlier, which is in Aravind, probably one cataract surgery generates the carbon emission equivalent to driving for about 25 kilometers. It equates to about driving for 500 kilometers in the UK. That's the amount of waste they generate with each cataract surgery, which is quite a lot of waste. We have a big responsibility. So Cassandra Thiel and the team at Aravind Hospital, Pondicherry, actually did a very nice study, and they found that the waste which we have in Aravind is about 20 times lesser than what it is in the US or the UK. Now, does this compromise care and outcome? See, the endophthalmitis rate, which we published about 2 years back in a consecutive series of about 2 million cases, showed that the endophthalmitis rate was about 0.02, which is similar or even lower than many other published papers from the US and UK. And this is just to show how much of waste we generate. This is one phaco case in the US versus 100 phaco cases in India. So we actually are leading the way in India, and it's very important for us to stick with what we believe and not to mimic the West in this area. As long as we are confident about our protocols and our outcome, I think we should stick to them. And this very recent editorial by David Chang, and I think this is a very well written editorial, and he says that the overwhelming majority of surgeons and nurses want more reusable options today. And there's more discretion on when to reuse products labeled for single use and greater manufacturer consideration of carbon footprint. So I think this is the way which the world is going, and I think we are on top of the game and we should continue to be. Again, this is a very interesting survey from ESCRS members, where they said that many of these members would like to consider short cycles. So either the 26% is doing it, and 65% would actually be willing to consider if the regulations permit short cycle. Reprocessing and single-use instruments, again 7% are doing it, and 84% would like to reuse it if their manufacturer would say so. Again, OR staff using the surgical mask same day, most of them are still using. So I think most of the surgeons and the medical teams are willing to reuse and reduce the amount of supplies which are using. So this is the overall feel. The final take on this is leadership is key, and ophthalmology having the highest procedural volumes, I think it is our responsibility to take it as a compelling opportunity and obligation to lead efforts within medicine to make our essential services more sustainable. Thank you.